Good afternoon to our guests from the East Coast, Central, and Mountain time zones, and good morning to those of you joining us from the West. Thank you for coming here today. My name is Cybele Bjorklund. I'm the Senior Vice President for Policy and Government Strategy at Virta Health. Our mission at Virta is to reverse type 2 diabetes, prediabetes, and obesity through person-centered care. We use nutritional therapy, technology, and an incredible coach and clinician team to help our patients reduce blood sugar and dependence on insulin and other medications while achieving clinically significant weight loss. First, a bit of housekeeping. This webinar will be recorded and we'll send the recording to all guests. We'll reserve 10 or 15 minutes at the end for your Q&A. All participants are muted, so please type your questions into the question panel on your screen. And our staff on the other side will catch those questions and feed them to us at the end for the Q&A. Today's theme in a nutshell is health disparities in employer-sponsored insurance. More than 150 million Americans depend on ESI for their healthcare, but historical data gaps and limitations in analyzing health outcomes across race, ethnicity, income, and other key demographic variables have made it hard to assess where we are and, importantly, where we need to go when we're looking at equity issues. Morgan Health and NORC at the University of Chicago recently published a first-of-its-kind data analysis leveraging 3 nationally representative public surveys and national vital statistics records. The report sheds light on some affordability and outcome challenges and opportunities in America's largest insurance market. While the findings are sobering, they may also help some plans and sponsors address potential equity barriers in ESI. I'll be interested to hear your thoughts about how employers and other interested parties can use these data to drive change, you being our guests. Today, we'll review the top-line findings of the report, dive into the details during a panel discussion with our Morgan Health experts, Orriel, Richardson, and Katherine Bobroske. Katherine is Vice President of Healthcare Innovation and Data Science at Morgan Health. As a data scientist, she supports Morgan Health's strategic initiatives by partnering with collaborators on their clinical impact projections, staffing models, and data-based insights. Katherine also contributes to Morgan Health's equity initiatives by working to establish a framework to measure and incentivize improvements in health disparities using medical and pharmaceutical claims data. Katherine trained in operations research engineering and has over a decade experience in applying techniques related to optimization, machine learning, and econometrics to the healthcare industry at companies including McKesson, Evolent Health, and Haven. She did her undergraduate work at Cornell and earned her master's degree and PhD from the University of Cambridge at the Judge Business School. Orriel Richardson is the Vice President of Health Equity and Policy at Morgan Health. Prior to joining Morgan Health, Orriel served in a number of key government positions, including at the Committee on Ways and Means in the U.S. House of Representatives, at the Centers for Medicare and Medicaid Innovation at CMS, and in the District of Columbia's Department of Healthcare Finance. Orriel earned her law degree from GW School of Law, a certificate in international human rights law from the University of Oxford, an MPH from Tulane, and her undergraduate from Howard University. It's such an honor to have you both here. Frankly, we all know the challenges in collecting reliable data on race, ethnicity, and other characteristics in both public and private coverage. Too often, policymakers, plan administrators, and others are forced to make decisions with subpar data, with many rationalizing that flawed data is better than no data. Given those historical data limitations, this report really is a breakthrough accomplishment. Orriel and Katherine, before we dive into it, or maybe as you dive into it, I'm hoping you can provide some context and share a bit more about the backstory of the study, why Morgan Health thought this was important, and what made it possible, aside from will and funding, which are 2 admittedly big issues. So I'll turn it over for you for slides, and then we'll dive into questions.
Thank you very much. So a pleasant time of day to you wherever you are across the U.S. And otherwise, if anyone is joining us from outside. It's a pleasure to be here with you today and to talk about this really important work. But we think in order to ground the conversation and just how important this work was to our goals as an organization, it's to give you a little bit of context about Morgan Health, who we are, and what we're accomplishing. So JP Morgan Chase decided to launch Morgan Health in May of 2021. Yes, 2021, so that they could sort of continue some of the work that they wanted to achieve when they were in a partnership with a venture called Haven. Haven was a three-party sort of undertaking with Amazon and Berkshire Hathaway, and it sought to really, disrupt healthcare in the United States. And I think if anyone here of the nearly 300 of you that are logged on so far understand why we do this work and why it's a constant learning exercise, is healthcare really is complicated. And that was a very, very lofty mission. So Haven shuttered in 2021 as well, but JP Morgan continued its aspirations to continue to make some sort of inroads in transforming healthcare. When Morgan Health was implemented and designed, that focus became very, very, very targeted on the 150 million Americans who rely on employer-sponsored insurance as the source of their healthcare coverage. So there are, three primary components to the way that we've been tackling our work. The first is we have $250 million from the bank's balance sheet to invest in solutions that help to further the mission that we've articulated for ourselves, improving the affordability, quality, and equity in employer-sponsored insurance. We also have a team of very, very, very smart people. A lot of them have backgrounds at CMS Innovation Center, who are working with our corporate benefits team to pilot different value-based care solutions within our own employee population. There are 150 million Americans in this space, but we feel to have credibility and to really give the benefit of our experience and our expertise that we've amassed, it's learning how things work in our own backyard and then deploying the lessons, positive or failures, frankly, which may be more important in some instances than successes, to the broader universe of ESI. And then also, as Katie's bio alluded to, we are really focused on doing some tangible work to understand the health disparities, the gaps in health outcomes that exist within our own employee population. Again, noting that innovation in healthcare really has been stymied by sort of the gray area of what to do in the space where unmet social needs really influence the way that people both access the healthcare system and the way that their health is then impacted by their experience with the healthcare system. So in thinking through all of those things and our desire to be, reputable when we share our insights, you have to start with an evidence base. You have to start with understanding what it is we're trying to tackle, and not just in a hypothetical way or using all of our best knowledge to make assumptions about how things translate into the employer-sponsored arena, but to really do the work to develop a baseline to do that. And so data is certainly not my foray. So I'm happy to be joined by Dr. Bobroske, Katherine, to talk us through those various aspects of why we did this work. So Katie, I'll pass it to you.
Thanks, Orriel. Okay, and we can move to the next slide. So as Orriel mentioned, one of the key kind of pillars that we have at Morgan Health is equity. And really early into the whole mission back in 2021, we realized that there really isn't a single source, a comprehensive picture of what health insurance for employer-sponsored insurance looks like in the marketplace. From a data science perspective, we can all know it's very difficult to draw insights when you have data kind of fragmented across the system. So one employer is going to have knowledge about their 30,000 employees and their health status. Another one might have only 200 enrollees on their plan. And even for large corporations like JP Morgan Chase, we don't have a clear picture of how our health of the population compares to the broader ESI market. So as we mentioned, a lot of our colleagues come from CMMI, and there are, as we know, many benchmarking reports for the Medicaid and Medicare populations. Unfortunately, for the most part, we don't believe that these are excellent comparisons for employer-sponsored insurance. So what we have done with a partnership with NORC. So NORC out of the University of Chicago has been an amazing partner on this study. They have a great reputation of creating really reputable bodies of work, and especially in the healthcare space, we just felt like they really understood what we were trying to accomplish with this analysis. So we were able to take data and insights from across several different data sources, all publicly available. Our goal with this report was not to curate any new data of itself, but really just to comprise a single report with all of the little snapshots of ESI, employer-sponsored insurance related data into a single report. So that is what we have done. I know that we'll be providing the link, but as just an overview, we not only provided kind of ideas about all of those pillars of kind of around that circle about chronic conditions, access to care, management of the chronic conditions, et cetera, but we also looked into disparities, particularly by race and ethnicity, by sexual orientation, and also by income level, wherever those were available in the different data sets. Okay, next slide. Great. So Orriel and I will kind of tag team on some of these kind of key differences, but we wanted to walk you through a few of the high-level insights that we found in the report itself. So the first one is around chronic conditions. Firstly, all of these conditions that we studied, which were asthma, high blood pressure, high cholesterol, diabetes, and obesity, are all prevalent, unsurprisingly, in the employer-sponsored insurance group. So we do have about 10% of the enrollees having diabetes, and almost half had obesity using BMI as a measure. We also looked at the abdominal kind of waist to hip ratio and found even higher results. So we can see through these graphs, we pulled out the ones which we thought would be of most interest to this audience, diabetes and obesity in particular. And we noticed that not only is there prevalence, but there are also what seem to be differences across the different races and ethnicities. We worked with NORC to not only look at this from a high level of just like unadjusted rates, but we also did the adjustment by age and sex to eliminate at least some of the confounders that could be explaining some of these differences. And in the diabetes measurements, actually found, if anything, those results were still statistically different from each other in the sense of the non-white races were and ethnicities, we were all of a higher prevalence rate compared to the white subgroup. And those differences in obesity also persisted after adjusting for age and sex. So from an employer perspective, this is really quite important information in the sense of when we are thinking through how are we engaging our members with, different point solutions or through the insurance company, making sure that the point solutions aren't just looking overall, but are we specifically engaging certain subsets and certain subgroups of individuals, as we find that it is not necessarily always the same when you look across the different subgroups of the burden of chronic disease that exists. So next slide.
So the report also did some significant work in thinking through what, it has become post-COVID an even more relevant area, particularly of concern for employers. And that's thinking through sort of the mental well-being and the behavioral health needs of the workforce. And we could certainly, extrapolate some of these findings to the things that, again, COVID has shown us. But even before the height of COVID, there were some concerning findings that we wanted to just generally highlight. And it's thinking through, for example, how even we think about substances. Tobacco, even though there have been great efforts in recent years to regulate it, to make it a little more difficult for folks to become addicted to tobacco, there's still 20% of enrollees in this population that use tobacco. And, I don't have to tell our audience in public health how critical that factor is when you think about how that contributes to different diseases and different chronic diseases and a lower overall quality of health. Similarly, 30% of the folks under this study reported issues with alcohol use. And I think, again, just thinking through tobacco and alcohol as things that are, everywhere in our communities, they're easily accessible. Those are concerning, and particularly, the label that says these, alcohol use may contribute to this and may cause health problems. That is just a concerning statistic overall, and has a lot of bearing, I think, to some of the other disparities that we know exist, as shown in this study. And similarly, the 19% of enrollees who who admitted to having used illicit drugs in the past year. I think we could probably, opine a little bit about that. If 19% admitted to using illicit drugs in the prior year, the number is actually probably higher than that in earnest. And then beyond that, it is generally probing a little bit about who those populations were that did admit to using alcohol or illicit drugs. And as the slide notes, the findings here are a little bit askew of what people traditionally think of when they think of health disparities, which usually tear to worse outcomes or higher adverse behaviors in a population that is from a minoritized community or a population that is not generally seen as the quote unquote majority. And in this case, white enrollees were definitely among the groups that reported higher rates of use in this area. And also our LGBTQ population reported some significantly high had alcohol and illicit drug use. And this is compared to, other enrollees of race and ethnic groups, and then also thinking through your quote unquote cis and straight populations as well. So then beyond that, the highest rates of severe behavioral health concerns and conditions were seen in the LGBTQ population. And these are just concerning statistics overall, just when you think of some of the challenges that we're experiencing in society as a whole, that group particularly faces. And so it is very important, I think, that this study showed that, even though, again, we believe that in the space of behavioral health and substance use, most surveys would still reflect an undercount in the actual burden of population on those issues. Next slide. Then we turn to another issue that is an area where most folks in general look at Medicaid as the largest sort of payer of births in the United States as the source or the root or the place where this problem really meets the road. But overall, maternal mortality in the United States is a crisis. It is abysmal. It is embarrassing. The mortality rate in the United States is 3 times that of other high-income countries. And we are, the only one of those countries in general that does not have some sort of universal coverage. And oftentimes what you see is if this person had Medicaid, they're going to get a lower quality of care. If this person has commercial insurance, they're going to get better care. And generally, there are studies that support this finding as well that show that that is not the case, that overall race and ethnicity do have more bearing than coverage source in terms of outcomes for maternal health. So in this particular study, one of the findings that we found to be very harrowing and concerning is the prevalence of C-section rates among enrollees with low-risk pregnancies, and seeing that there was a significant increase in those C-section procedures among Black, Asian, and Hispanics as compared to white birthing people. And in this situation of what happens to a low-risk pregnancy that is then concluded through an operation is that those operations can, of course, place that otherwise low-risk pregnancy in a space where that person is at risk from all the complications that come post-operation. And at the same time, it's thinking through some of the practical implications of seeing this within an employed population. Oftentimes, C-section can be scheduled. And in the sense of people who need a little bit more control over their schedules, they need to make sure they have the ability to return to work. Those are also some practical considerations within this population that we would like to explore a little further in future work. Next slide.
And the last kind of key set of findings that we would like to highlight is around the barriers to care. So we all are very aware that the costs in the U.S. healthcare system can be high. There's lack of transparency around billing, and often it does take a certain level of health literacy to be able to navigate the in versus out-of-network structure of many of these private insurance plans. So it can be very easy to assume that access to care, financial barriers, and the like primarily affect the uninsured or those with government programs such as Medicaid. But we found something really different in the ESI data. So despite being employed and having insurance through their employer, more than 1 in 10 of our enrollees found that they had difficulty paying medical bills. The enrollees also appear to be making decisions on their health based on what they can afford. So some of the patients in this first graph, they reported skipping prescriptions or taking less of their medications to save money, or they didn't fill the prescription at all. Others have reported delaying or not receiving medical care, and that is everything from preventative care screenings to mental health and even surgical procedures. So another finding was that food insecurity actually does exist in the ESI population. So 7.7% of our enrollees reported having difficulties accessing healthy, sufficient, and safe food to promote their well-being. What this looked like and how it was recorded in the survey was asking members if they maybe ate less because of lack of food or skipped meals for that same reason, or they weren't able to afford to eat well-balanced meals. Food insecurity, unfortunately, is most prevalent in the subgroups that also have higher rates of many of the chronic conditions, including diabetes and obesity. So we can all imagine that these effects are really compounding. And then the last thing we'd like to highlight is around the access to care. So having a usual source of care, such as a primary care clinician or a doctor's office that you go to when you're sick, is a very useful proxy for whether the patient has good access to medical resources. And despite all of these enrollees having insurance coverage, there's a clear correlation between having a usual source of care and an enrollee's income level. So these lower income enrollees are also more likely to visit the emergency room. What we found in the study was it was 20.1% of enrollees in that less than $50,000 range for income were going to the emergency room annually or in the past year versus only 12.9% in that highest income band. And obviously such visits are really costly, especially out of pocket. And unfortunately, this pattern seems to be disproportionately burdening those with the lowest income. Next slide.
So I guess to wrap up this part of the webinar, the idea of what we found really solidifies our approach to prioritizing health equity as a key pillar of our overall strategy. Health inequities, health disparities, those are population level issues. And as we often, and my colleagues often hear me say, if there was a separate healthcare system, a separate set of facilities, separate set of doctors and all of that, then we could probably think about this less than a population level concern. But we just need to make sure that the employer space is included in the conversations that are broadly happening around ways to improve health equity in the United States. And thinking through how important that is, not just to the overall spend, which is something that is front of mind for employers, but also the ability of your workforce to feel like coming to work and being productive and making sure that your organization can achieve its mission. And so it's thinking about the needs of the population, but being intentional to really understand them and being proactive about not putting upon the employees or making assumptions, but doing the work and putting the elbow grease into really learning what the data shows you about your population. And thinking about how then that 150 million American piece of the pie could really help to move the needle on a conversation that continues to, in some ways, experience inertia because it is just part of the system in terms of the public programs, the M's, if you will, that are trying to focus on tackling this on a regular basis. And then it's also acknowledging that employers have other levers, particularly large and jumbo employers, by being really valued employers in a community as a whole, to find ways to be creative, to partner, and to meet the unmet social needs of their employees. And even thinking of this not necessarily being something that is overall going to be a benefit in the way that we think about benefits in ESI, but it could be something that falls more in the rubric of an ESG sort of commitment and something that is like a community corporate responsibility sort of like undertaking. So those are the things that we think are very top of mind as we do this initial sort of report here and continue to use these findings to reiterate and to evolve how we look at future studies in this space. So with that, I will turn it back over to Cybele.
Great. Thanks, Orriel, and thanks, Katherine, for that overview. I really do think this is such interesting work. I first saw it right after you released it because I had been coincidentally looking for data on ESI enrollment by race and ethnicity. We at Virta have served primarily an employer-sponsored insurance community, and we were looking at our own data by race and ethnicity and ADI and trying to compare it in some other places. And I wanted to see the distribution among employers. And so my first stop was Gary Claxton's great employer health benefit survey at Kaiser Family Foundation. It's usually my go-to for ESI trends and details, but I couldn't find the breakdown. So I called Gary and asked him about it. He said, no, we don't have those data. And he wasn't even sure where I could find them. And then a little while later, you released your report. And so it really does, I think, contribute to the conversation as everybody's neck deep in equity work and trying to really evaluate what the needs are and where they need to go. And in some ways, and this isn't pejorative, I found it predictable, right? Some of the disparities that you're reporting in the employer population on chronic disease looks really similar to what we're seeing in other forms of public and private coverage. And so that's comforting on one level to say, okay, problems we have, in one place are a problem elsewhere. So we systemically have to get together and address them. But then became what more interesting is sort of course, where there are differences, and then in the unique tools that as you mentioned, that the employers have to address them. So for diabetes prevalence, for example, not that I would coincidentally be interested in that, by racial and ethnic groups in ESI does look a lot like the population prevalence, where rates are much higher among Black and Hispanic employees relative to white. But I was surprised in your data to see prevalence highest for Asian employees. CDC statistics estimate prevalence among Asian Americans at 9.5%, but your analysis showed 14% for Asian Americans with ESI, even higher than the Black and Hispanic group reporting. So do you have, Katherine, this might be for you, more of a sense of why that might be the case? And it's just such a big difference. I wonder whether there are definitional issues or data or noise or what is going on there, because that is what appears to be very significant.
Absolutely. Yeah. And I think, Orriel has a lot to add, I think, on this as well. But there are some, like one of the things that the Asian group, as we defined it, combines is different regions of Asia as it's defined. So everywhere from like India to China, kind of the Southeast Asian region as well. So all of that together, there are very different conditions within those different subgroups. So there is a little bit of this is an aggregation. And along those lines, depending on how the employer-sponsored insurance group looks. So if there is a higher proportion of representation of certain subgroups within that, in the ESI enrollee population, then that obviously will change the overall findings that we're seeing at the aggregated level.
And I was just going to add that it seems like in that rubric, it's also an opportunity for future work in this space to dive a little deeper, thinking through, of course, the issues that we have with how we aggregate certain racial and ethnic groups and sort of the bias that goes along with the ill-fated moniker of a model minority in any space. But it's also thinking a bit about the opportunity to dive into the occupations within these sorts of samples and thinking through what is, for better or worse, generally a sedentary workforce that has access to employer-sponsored insurance in many cases. Those are probably some general sorts of root causes of why you may see that skew within this population. And I think if there's an overrepresentation of one group, for example, there are some Asian subgroups that are heavily in tech careers, and those are programming jobs. They're heavily in sorts of classified jobs where they sit and program on a computer all day. And those are just things that this, I think, baseline study gives us enough breadcrumbs to continue to do a little bit more and provide more of a less survey, more qualitative and rigorous study and looking at some of those classifications and how they may factor into folks' overall outcomes.
Well, I think that is super interesting to dive into job classification and, even further sort of peel back the layers of the onion about what types of workers have access to what, who's reporting difficulty. And to Katherine's point on the range under classification, not job classifications, but racial or ethnic reporting classifications is true. Even in the CDC data, they've got, ethnic Chinese at I think 5.6%, and South Asian Indian at 12. So, maybe what this means is when you're looking at a workforce, it's, the populations that are reporting this data are showing up much more on the South Asian Indian side of the equation. But I thought that was interesting. And I think the other thing, as long as we're still on diabetes and obesity, is that you do cite those as two of the top conditions with glaring rates of undiagnosis, particularly among minority groups. And this is alarming, although also consistent with CDC data. Black and Hispanic patients with diabetes are both more likely to have diabetes and more likely to lose limbs, eyesight, kidneys, even their lives relative to white counterparts. How are you able to measure prevalence for people who are undiagnosed in your data? And what might explain the lack of diagnosis in these conditions and the demographics compared to other conditions?
Absolutely. Yes, no, happy to answer that. And I think also I've seen a couple questions in the chat just about the data sources in general. So I think this is a perfect time to combine these questions. So the 3 surveys that we used and that NORC really pulled together into this report were NHANES, so the National Health and Nutrition Examination Survey, also the National Health Interview Survey, National Survey of Drug Use and Health, and then in addition to that, we also combined the National Vital Statistics Systems, the natality data. So basically from all of the birth certificates, it covers over 99% of the births in the US. So and all of these data were from 2019. So it is kind of a pre-COVID snapshot. In terms of diabetes, so that those data in particular were pulled from the NHANES survey. And in this survey, the patients were identified as having diabetes at all through a combination of self-reports. So the patient was told by the doctor that they have the condition, or they reported taking medication to control their diabetes, and then also through laboratory tests. So there were kind of on-site availability of HbA1c testing, in addition to blood pressure and, measuring your BMI. And anyone who measured 6.5% or greater in the HbA1c was considered as being a diabetic. So then the analysis, as you're saying, kind of split our diabetics into 3 categories. So we had diagnosed and under control, diagnosed and not under control, and then the undiagnosed. So being diagnosed and under control is those subset of patients where their HbA1c is below 6.5%, but they know they either have or had diabetes. In contrast, it is the undiagnosed diabetes are people who had that HbA1c level as high, even though they'd never recalled being informed by a clinician that they have that condition. And the differences across the undiagnosis, across race and ethnicity, are statistically significant. And I mean, they're actually quite shocking, I think, in some ways, and there's a number of different reasons that could explain some of this. I mean, everything from access to care and diagnostic testing to continuity of care, especially in the primary care setting. So all of this kind of goes into our single loop of just we need better care quality for certain subsets of the population. And really, from an employer perspective, we were also identifying undiagnosis as one of the key issues that they could engage with. A lot of employers already incentivize through their wellness programs or whatnot, employees to be taking biometric screenings. They might even have an HbA1c that they take annually, some sort of test, or it's covered through their insurance. And I think our question to a lot of the employers is, first, are these programs in place? And if they are, what are we doing with the results? Are we making sure that the people who flag with the high levels of HbA1c are getting connected to the high quality providers? Are they receiving the resources that they need to get further testing and treatment if that's applicable? And then from that race and ethnicity disparity perspective, are we also looking at kind of how we're closing the loop with keeping in mind all of the different cultural contexts? So, different languages, different social needs, and all of that needs to come into the picture if we're really trying to address that high rate across the different subgroups.
I think that's so important too, to just talk about how you connect the dots. So, on one hand, I think as employers grapple with equity issues, there are fundamental data gaps and sensitivities around what you can collect, what people want to give you, and how do you get a baseline assessment of your population. But then it is that critical next step that once you know, what are you doing with it and how are you put the wellness fairs out there, but if you don't, connect them when you see the elevated A1C to care, or provide other necessary follow-ups, then it's sort of a tree falls in the forest and no one hears it. And it reminds me a little bit even of the Medicare Advantage debate, where there's a lot of health assessments being done in order to support coding. And then the question is, how can they take what they learn in those assessments and put it to work to help and support the beneficiaries? So it's very interesting. I also thought it really interesting that you looked also at sexual orientation as a separate cadre of categorization for disparities. And given the stark differences in severity of behavioral health and substance use issues and related outcomes for LGBTQ employees, what do you think there? Do either of you have ideas about what employers and health plans can do to reach and actually support these populations more effectively? Are there any best practices that you've heard of that you can share? I've seen some of the questions coming across in the chat if people are looking for strategies. And so I think trying to talk about some of the concrete strategies as you all have been working with employers, that would be useful for our audience to hear.
Overall, this is an area where I think we're all learning at the same time, frankly. And one of the things that is very promising about working at JP Morgan is that this is a company that really values full-fledged diversity of its workforce and provides support for all facets of what diversity means in terms of the beauty of humanity. And so the sort of like what we're doing about it, I think first is that you have to have an environment where people feel safe enough to identify. And then you have to also ask and listen. Once you've asked a question, you have to listen. And if you ask and listen, but then they don't demonstrably see that you're taking actions that address the things that they've cited as problematic or barriers to care, then you'll find that you don't get honest answers in the future, and you may see a less diverse workforce as your company and organization's workforce evolves. So I think the most important thing that this study showed us is the need to dive deeper, particularly with intentionality around looking at not just sexual orientation, but again, as I alluded to earlier, thinking through gender identity and the diversity of issues that both categories of individuals face when they're interacting with the health system. And again, recognizing this is not just an ESI consideration. This is an entire United States of America. The world is learning at the same time how to better accommodate the needs of people who do not identify with the quote unquote norm. And I think this is one of the more fruitful opportunities for the work that we're doing here, is to really, be thoughtful about voicing the needs of the unmet needs of these populations in the work that we're doing, and doing it in the context of employer-sponsored insurance. And so I think more to come there. If you invite us back for a part 2, when we do a follow-up on this work, we hope to have more tangible examples to share. But I'll just say that that's where we're starting. We're asking the questions of the groups themselves. And one of the ways that we can do that within JP Morgan is, figuring out and innovating with the groups themselves. Like we have business research groups where there are employees who are brave enough and talented enough to speak truth to power in terms of telling this corporation, these are the things that my population needs to thrive in the workplace and in life in general. And those are groups that we have across race, ethnicity, gender, and also our pride group with LGBTQIA issues. So we will continue to leverage those groups and partner with the things that we learn and continue to learn more, and be intentional about making sure that our solutions incorporate and or prioritize the needs of those populations equal to others.
No, I think that's great. And I think it's true. I think of Morgan Health and what you're doing through the investment piece to try to help support innovative solutions. You think about it as you're serving, but of course you as a major employer have your own whole health plan to be working on and serving your associates everywhere. The data in here on barriers to care and food insecurity were also, I thought, very interesting. These are obviously some of the social determinants of health drivers that help explain some of the health disparities we see downstream in actual outcomes and prevalence. And on food insecurity, I was struck in the report itself, not in the slide you showed, around the variation under the average. So I think many people would find even 7.7% of people with ESI reporting food insecurity startling. I think there's conventional wisdom: if you're employed and you have health insurance, aren't you lucky? You probably have no problems here. And so I think surfacing that there's 7.7% reporting food insecurity at all is interesting. But I'd love to know a little bit about the range under it, where Asian employees reported at 4.8 as the lowest end, and the Black employees were at 16%, a more than 3x difference. And I just would love to know, are those statistically significant differences? That feels like something people should pay attention to. And then I also wanted to ask you, as you answer that, that a number of large employers, I think, have really begun to lean into food. I was at a business group on health meeting this week, and people are talking about innovative and interesting approaches. And some of that they're doing in their benefits world, under the umbrella of all their benefits, where, of course, it's a resource-constrained environment, and they have to make trade-offs between what they do in the plan itself and what ancillary benefits they offer. But I think if you could talk to us a little bit about what you've seen around employers and food insecurity, that would be really interesting, particularly if they're doing something outside of the envelope of benefits per se.
I would leave Katherine to talk about the question of statistical significance first, and then I'll chime in with.
Right. Yes. So the differences, are definitely statistically significant between groups. Specifically, what we compared was the Black to white and then the Hispanic to white. Those were two groups where the differences, even after controlling, were about 10 percentage points, and then 6 percentage points, respectively. So definitely a yes in terms of, are these a meaningful thing? Orriel, context.
And I mean, food is one of those things that's just tricky, because the amateur anthropologist in me knows that food falls within the rubric of culture, which means that there are just differences in folks thinking what is sufficient food, what is nutritious food. And so while there's an education element that I think a lot of employers need to consider, they can't consider it in the way of having a one-size-fits-all approach into what people need in terms of like education around nutritious and healthful foods. But at the same time, employers are not trying to get into the business of subsidizing the grocery bills of their workforce. So at the end of the day, it's some sort of like hybrid approach to it behooves, particularly self-funded large employers that basically pay for their employees' healthcare outright. It behooves them to understand the role that food insecurity may play in terms of overall health. But then at the same time, you don't want to see, the sort of world of healthcare benefits skyrocket yet again, because now we've incorporated in another subsidization of the U.S. food program. So I know there's a comment in the questions also that talks about you can't solve inequities if you keep talking about affordability. But I think the idea is we talk about affordability in terms of health coverage, but this question gives us the opportunity to do what we really need to do to address health inequities that cause health disparities. And that's be more collaborative, be more interdisciplinary, and just be creative in the way that we think about these issues. So in the conversations that we've had in the year plus that I've now been at Morgan Health, one of the more interesting innovations that I heard around the issue of food insecurity came out of Texas. And there was an airport authority that was looking at its employee population, listening to some of the concerns that employees expressed, but also looking at some of the health outcomes and the healthcare spend within their employee population. And what they discovered was they were suffering from a scourge of metabolic conditions like so many others. What do you see with that? You see people who are obese, you see people who have high blood pressure, hypertension, you see people who are borderline diabetic or have diabetes, all of those sorts of things. And then they also did something that I think a lot of employers need to do. They looked around and they saw, well, when our people come to work, what are their food options? What are their options if they work the early shift? What are their lunch options? And it was completely surrounded by fast food options. And when they talked to the employees let them know, hey, we don't necessarily have access to some place during the workday to get healthy food. And then after work, most times either those things are closed or maybe they live in a community that didn't have access to fresh, healthy food. And so what they did was they piloted co-locating a farmer's market on site 3 days a week. And I think it actually started 1 day a week and grew to 3 days a week. But it was very popular, very well received. And they started to demonstrably see not just satisfaction of their employees in terms of what they could get and kind of the convenience of it. They started to see that come out in the wash of the health outcomes. And so I don't necessarily think that all of the issues that this NORC analysis, this baseline analysis shows us are going to be add this to your benefits, put this in the benefits bucket, add more to the benefits. But it really is employers are uniquely suited to look more holistically at how employees interact with the 8+ hours a day that they provide, even if they work hybrid. There are all these new services now that do things by delivery, but there are just other ways to think about the importance of convenience and getting a lot of folks to adapt how they interact with healthy food, particularly. So that is one of my favorite examples, and that literally personifies the type of creativity that I think we need throughout all of the unmet social needs.
Yeah, I love that. And it's also, again, something outside the envelope of the benefit spend. It's an organizational effort and an accessibility effort of getting it there. So I had one final quick question, but I want to move through it fast so we can try to get to some of the ones more of the ones that have come in the chat. I know we've done a couple along the way here, but my final piece also, and I think, Orriel, this is for you, was on the barriers to care that you reported and how that might be used by employers and plans as they're engaging in plan design. So if we have employees already delaying and foregoing care under the coverage, how can that concretely be used to address plan design issues? And I heard an employer this week, again at this other meeting, talking about an amazing redesign that they were doing and tied into their equity strategy, where they also, frankly, as part of the redesign, were having employees participate in survey and yielding data that they could use to help them, but then they were giving them a different level of benefit for basically being willing to share the data so that they could then use it to sort of plug gaps that they had. But there's, again, I think many people think you have employer-sponsored insurance, you're employed, you have income, you have some level of education, you must be doing all right. And we know that it's hard, even when employers are doing their best to balance those needs. So what do you think could be done around these data for plan design?
Well, when I first thought about this sort of this issue that you posed to us, I was like, okay, I could say this, I could say that. But then I realized we actually are, as an organization, working through this right now. JP Morgan and the benefits team and Morgan Health recently launched an advanced primary care pilot within our Columbus, Ohio market. And this is with Apri-Health. Apri-Health is the new corporate, entity that Virta Whole Health and Castlight combined to form. And the idea with the pilot that we are operating in Ohio is that advanced primary care can provide more affordability because it can provide better quality of care. It can help to work on more equitable care, and it can generally be something that is convenient and incorporated into a regular benefits schematic. So we have these clinics that are near site that basically have nodes into the community across Columbus. The employees, I think there are about 40,000 or so that we're covered lives that we're talking about here. The employees and their families have access to these near site clinics. They have access to this advanced primary care, which I like to think of as a primary care hub. So they come there, and it's not like your urgent care where you come and you have this like discrete interaction. You have someone who's interested in the last time you were here, you looked a little high on your hypertension number. So did you follow through with the referral that we gave you to this organization? And has the ability to both understand what the person is saying in terms of, yes, I did, or no, I didn't, and also see what happened when that referral came. And it really wraps around this person a more, and I don't want to use the word, but I don't have a better one, a more accountable, form of getting their primary care, both accountable in terms of that entity, APRI, that has said, We're going to partner with JP Morgan and Morgan Health to make sure that as part of their regular benefit structure, we are the best conduit for primary care that this employee could possibly get. And so we'll share that learning. We'll share what we learned from that. But the idea of providing folks a system that already has in place the referral opportunities that will close loop those referrals, that will follow up, that's something that could be a game changer when you think about the premium of time. And when you think about folks who are employed, usually that's what you look at. Another area, I think, when you consider like what these sorts of findings show around plan design, it's the need to, again, adapt in a creative way. So the self-funded employers have a wonderful opportunity, for example, to decide how they want their carriers to deliver the care plan that they've designed, the healthcare plan that they've designed. And if the employers can do something that uses this study as a baseline to say within our population, we see something similar, this is something that is generally around the population. And so I think that gives them the wherewithal to then go to that table with the prospective carriers and help to negotiate around how could you help us to close this gap within our own employee population. And then the last thing that I'll say that we're trying to do to then eventually share with the larger ecosystem that's interested in ESI is our employees in California have the opportunity to be enrolled in Kaiser. And so with Kaiser Permanente in California for our employees, we are working on health equity related performance guarantees. So collaboratively identifying quality measures and conditions that are of interest, working on making sure that we have ascertained the race ethnicity data within those conditions for the population that's covered, and then working in future years to figure out, okay, how much work has been done to close any gaps that we see across race and ethnic groups as it relates to this chronic condition or this quality condition, quality measure. And again, those things have not traditionally happened in the employer-sponsored space. And so we don't have the guidebook yet, but we're working on writing it now. And we will share those learnings as we come to them. We will even be quite forthcoming about the things that don't work, which again are often more helpful. But doing something, I think, and trying something is the thing of what has to happen in plan design. And I have to say it's been really fun partnering in an organization such as this, where they have a robust benefits plan already, but thinking about ways to evolve and make sure that we're first in class now and always is very enriching work.
No, I think that that's great. And people be interested in hearing again. I think you're right. It's as helpful to hear what didn't work as what does work. So hopefully it will all work, but there'll be lessons within there. There was a question early on, Katherine, that might be more for you about how do all payer claims databases fit into this work, and is that a useful tool that folks who want to dig into disparities can use? I don't have enough information around what's in the claims forms that can be extracted to allow you to pair up there, but I've done some work in the past with Fair Health and others who I think do have enormous data sets and an ability to do some de-identified matching and other pieces.
Absolutely. Yeah. Claims are kind of the bread and butter of a lot of, employers. It's like the main thing that we have to work with. Obviously, we can supplement that with things like biometric data, race and ethnicity data, as that becomes available. But one of the big challenges is trying to extract meaningfulness from the claims themselves, acknowledging that all we're really seeing are the interactions that the patients have with the healthcare system. And as we noted in the undiagnosed groups, there are subgroups who maybe interact with that system much less. They're less likely to show up in the claims. So as a result, every single data source that we work with is going to have bias in some way. The claims are going to have that kind of like missing data problem where we're not going to be able to absorb or observe holistically what is going on with the patient. And likewise, employers have this very fun problem where our population is constantly churning. Hopefully not that often. We like to keep people for long periods of time, but at the same time, we don't have the full kind of health history that, say, a Medicare database would have when you're dealing with claims. Personally, we are using our claims data in the best of the ways that we can to start comparing what is happening in our own population. We are expecting to have slightly, different kind of overall rates of identification just because of the different data sources, but we're finding a lot of similarities in, our population, just as it is such a large employer to the broader ESI. And I think that's also one thing that we'd love to share just about this report in general too, is, not every employer group is going to have ready access to things like income pay tier and race and ethnicity data that's easily combinable with their claims, or there might not be the resources to be able to analyze all of that jointly together. And so this report, at least for us, as we were starting as Morgan Health, before we can go into the deep dives of, looking at our own disparities and being able to kind of understand that in its own way, this report was really just serving as also like a guiding North Star of, if we can assume that our population is more or less representative of the rest of ESI, what can we do and where do we start prioritizing our efforts?
Yeah, that's to me, I thought one of the utilities of this is just sort of the signaling, right? Yeah. These are places you might want to look, some of which are predictable, others were surprising, and take a look there. We did, well, there was one other question I wanted to get to, but we're really almost out of time. That the last thing that I was curious that you guys, I think, have not gone over yet, but would be interesting is whether you plan to repeat it on a regular basis so that you can identify trends. I know Orriel's talked about some of the work you're doing for the Morgan Health Plan and such, but, are you adding more issue areas? Like, when might be the next tranche and what would be in it? I don't know whether this is kind of a one and done landscape setting or whether you think there'll be a periodic revisiting of it.
Yeah, absolutely. Well, we definitely do hope that we can repeat or expand on this study in the future. I mean, I think even in that year or so since, we've been starting to work on this study, we've learned a lot about, what bits of information employers need to have in order to really dive into this space. One of the most important things to note is that the study does come from 2019 data for the most part. So when we're dealing with COVID and the effects, we know that so much has changed as a result of COVID, at least at a national level, the uptick of virtual care and then the slight, recession of that as well. And the way that people kind of avoided their preventative cancer screenings, and how is that all impacting specifically the ESI? So if we are able to refresh that, is like, those are the types of things we're really looking forward to understand, because it is a slightly different landscape that we're kind of doing our work into now. And so being able to compare to a more up-to-date, after the COVID kind of pandemic started, is going to give us just a much better jumping off point to really start closing the disparities that are the most impactable in the population.
And I think that's a perfect way to wrap up. We actually had somebody ask what year were the data from, and so you mentioned that, but I do think there were other questions in the chat that we didn't get to around hybrid and what's being done to support, women and caregivers, which is a perennial question, but I think especially the hybrid issues, there's really so much that could be looked at now with a more current look at the data. And we're really glad to see you guys diving in here. People in the chat are hungry for actionable insights there, and people are asking recommendations, what can be done, on behavioral and others. So I do think, continuing to share out best practices as Morgan develops them and hears from people would be important. We'll do our best on the Virta side as well. And really want to thank both of you for coming and spending time with us today, and thank everybody who dialed in, and hope you had an interesting hour with us. Please download the report, and the risk of making enemies, not friends, reach out to people if you've got questions about the report. I've always done that, and I'm always surprised who actually gets back in touch with you. So thanks again. We really appreciate your time, everybody. I don't know, Katherine or Orriel, if you have any parting words, but.
Thanks so much for allowing us to share this important work. We really appreciate it. It's always good to talk with you, Cybele.
It's really important. Thanks so much, guys.